Imagine not being in a town like Saxe-Baha, where the nearest clinic is a short car ride away. Imagine instead living in an isolated rainforest village. And you wake up one morning and you panic because you have a fever, and you know that means you likely have malaria. And you also know that in order to get the treatment you need, you have to haul your frail body into a canoe, paddle across a river, and hike for up to 2 days before reaching the nearest health center. It's an impossible situation, but it's not just the situation of one person in one far-off village. Around 1 billion people go their entire lives without ever seeing a health worker. As we heard from Pap this morning, the world is set to be short 18 million health workers by 2030, and that disparity is really only getting worse. The standard solutions, building more clinics, hiring more doctors, are necessary, but they're not sufficient. Doctors and clinics have conspicuously failed to reach those living in the most remote communities. More than that, they've also failed to reach some of the most vulnerable in our cities. Universal healthcare delivery, or universal healthcare access, requires universal healthcare delivery for every person in every village. And we can get there by seeking new opportunity in an old idea: community health workers. So using community members to deliver healthcare is not, as I said, a new idea. Community health workers, or with apologies to Jess Mack, CHWs, have been used and widely promoted since at least the 1970s as a way to deliver primary health care to those living in the most resource-deprived settings. Randomized control trials, for those of you in the know, basically rigorous studies on small-scale programs, have indicated that these health workers can deliver a diverse set of health interventions, everything from birth control injections to HIV care management, and that ultimately, community healthcare workers can reduce child morbidity and child mortality. But the most recent studies on large-scale national health programs in Ethiopia, in Burkina Faso, in Malawi, have found that these programs had no effect whatsoever on mortality. So what's going on? There seems to be something about the way that these small-scale programs design and implement community health worker programs that doesn't really get replicated when we scale them up. Now, basically, the secret sauce is missing. The standard way that community health workers have been deployed is that a village chief will pick a community member, typically without testing their qualifications, for a couple days of non-assessed training. Unsupervised, unequipped, and unpaid, community health workers, at least in their most conventional form, often fail. But it's not really their fault. Think about it. If you had a factory and you didn't supervise, pay, or equip your employees, what type of product do you think you would get? Yeah, probably a non-existent one, and that's exactly what we see too often when it comes to healthcare. Those who never had access to healthcare ultimately never get it. In order to close the healthcare delivery gap, we need to do things differently. Not just with medical innovation, but with radical collaboration for better design. Unfortunately, we in professionalized civil society are not so great at cooperating. I hear some laughs in the audience. We know that. We know that as organizations, we tend to emphasize our own growth and push our own brands. And too often, we see each other as competitors rather than collaborators. We are schooled to put our own organizational interests first, and as a consequence, well, it doesn't really work out when our ultimate goal is systems change. We're not trying to, win a market share battle here, folks. We're trying to change and improve public sector health systems. So we got to take a different approach. Luckily, 6 organizations are bucking that trend: Hope Through Health, Living Goods, Muso, Last Mile Health, Partners in Health, and Possible. So each of these organizations, you may have heard of several of them, have independently developed really high-performing community health worker programs. But they recently came together to compare their approaches. Understanding that academic evidence, as I shared, tells us the community health workers can work, but not really how that happens, these organizations cooperated to try to identify operational insights based on their own practitioner experience. So in other words, they were trying to locate together the secret sauce. Now, today, I want to share a little bit about what we found and invite you to join us for what's next. So, to be honest, it's a little bit difficult to summarize an exercise whose precise value is not in high-level takeaways, but rather in that nitty-gritty operational detail. But I'm going to try to do it for you anyways. As it turns out, the way that these organizations implement is aligned in several key ways, and we've tried to distill those similarities into 8 design principles, and I'm going to share them for you now. We tried to focus on areas that are not typically areas that are debated within the community health space, or policies that are typically found in programs across the globe. So, what are the 8? Number 1, community health workers should be accredited. Actually, the majority of community health workers, startlingly, have never had their knowledge or competencies tested prior to practicing. And these practitioners have found that for quality, safe care, it's an imperative that community health workers meet a minimum standard prior to carrying out their work. Number 2, community health workers should be proactive. And what does that mean? Fewer kids die when healthcare is proactive. That means that rather than waiting for patients to come to them, community health workers are going door to door to seek out patients and provide care to them in their home. Third, continuously trained. Again, this sounds obvious, but too often community health workers are simply given, an informational PowerPoint and sent along their way. But education doesn't work like that. Continuous medical education is used for every single other health cadre, and it should also be used for community health workers. It shouldn't just be available to them, it should also be required. Community health workers also benefit immensely from a dedicated supervisor. So not someone who's kind of splitting their time at a clinic, which ultimately ends up with them spending all of their time at a clinic, but a supervisor whose sole job is to assess patient experience and provide one-on-one coaching to community health workers in the field. Number 5, as we already heard from Nick just a little while ago, community health workers are at their best when they're integrated into strong public sector monitoring and evaluation systems, where data are used to improve programs, and they're also used to improve community health worker performance. Number 6, it's incredible that I even have to say this, and I hear some, again, knowing laughs in the audience, but the poor should not be forced to volunteer to guarantee their own right to health. Yeah. Community health workers should be compensated financially at a competitive rate relative to their respective markets. Number 7, community health workers cannot be deployed in a vacuum. I hate to break it for the folks looking for a silver bullet, but in primary healthcare, there just often isn't one. And the same is true for community health workers. Community health worker deployment needs to be accompanied by investment in the accessibility, capacity, and quality of the primary healthcare facilities and providers to whom community health workers are linked. And finally, community health workers have to be accessible. So where possible, in order to improve timeliness of care and equity of care, user fees should be removed. The 6 organizations released these principles and a lot of that nitty-gritty operational detail in a report in December. And the results have so far, or the feedback and uptake has thus far been really incredible. It was accessed, I think, by 1.3 thousand people from 60 different countries in the first week after it was released. And if you want to join those folks, you can head to www.chwimpact.org to check it out. and we'd invite you to do that. But I want to talk about what comes next. And the ultimate goal of this kind of budding coalition of practitioners and implementers is to leverage practitioner experience to support national governments in creating high-impact community health delivery systems in their countries. And we're already working with practitioners in Madagascar and with one of the largest financing platforms for community health workers to improve healthcare using some of these principles. Now, universal healthcare is obviously a lofty goal, though, so true change is going to require a broad alliance. And these organizations, by choosing not to compete, but rather to cooperate, are already making a bold statement against the dominant paradigm of fractured technical support and unnecessarily wasteful resource allocation. The World Health Organization noted in a report that there is no longer any question of whether community health workers can be key agents in improving health. The question now is how their potential may be realized. Which sounds great, but the problem is that that report came out 20 years ago. Meanwhile, we have conspicuously failed to reach the promise and fulfill the promise of community health workers to help achieve universal healthcare delivery. So we want you guys to join us. Radical collaboration can help good design spread faster. Together, our voices are stronger, our resources go further, and we can do more for our patients. So if you're a community health worker implementer, join us. Help us refine and institutionalize good quality healthcare everywhere. If you're a philanthropist or a funder, come talk to us about joining foundations that have already committed to using these principles to discern program quality and help the programs in which they're already investing reach their full potential. If you're a policymaker, help lead the way by institutionalizing these principles within national or local programs. Community health worker programs require immense effort to design, scale, implement, and maintain. But they also offer tremendous opportunity to increase access to healthcare for all. Nobody should die because they live too far from a doctor. And if we give community health workers the tools and support they need to succeed while holding them to rigorous performance standards, nobody has to. Thank you.